I am an assistant of Department of Traumatology and Orthopedics at this big health. Now, today we talk about the lecture, Degenerative Diseases of Joints and Spine Columns. Okay, first picture. Okay, take a time. First one is definition, also known as degenerative joints disease or Untitled, progressive loss of cartilage with demolating of subchondral bone and progressive deformity of the joints. Cartilage destruction may be a result of a variety of etiologies. Next is osteoarthritis. It simply is OA definition, the repair mechanism of tissue absorption and synthesis get out of balance and result in osteophyte formation, bone spurs, and bone cystis. Okay, next picture, osteoarthritis OA. OA is the most common form of arthritis and the most common joint disease. Most of the people who have OA are older than age 45, and women are more commonly affected than men. OA most common occurs at the ends of the fingers, thumbs, neck, lower back, knees, and hips. Age factors. Age is the strongest risk factor of OA, although OA can start in young adulthood. If you are over 45 years old, you're at higher risk. Female gender. In general, arthritis occurs more frequently in women than in men. Before age 45, OA occurs more frequently in men. After age 45, OA is more common in women. OA of the hands. Okay, next one. OA risk factors. Hereditary gene defect. A defect in one of the genes responsible for the cartilage component. Collagen can cause deterioration of cartilage. Joint injury or overuse caused by physical labor or sports. Traumatic injury, examples ligament or meniscal tears to the knee or hip increases your risk for developing OA in these joints. Joints that are used repeatedly in certain jobs, maybe more. Symptoms. OA usually occurs slowly. It may be many years before the damage to the joints becomes noticeable. Only a third of people whose X-rays show OA report pain or other symptoms. Steady or intermittent pain in a joint. Stiffness that tends to follow periods of inactivity such as sleep or sitting, swelling or tenderness, crunching, feeling or sound of bone rubbing on bone when the joint is used. Okay, this one is radiographic diagnosis, asymmetrical joint space narrowing from loss of articular cartilage. Okay, second picture was X-ray, normal knee X-ray picture. First one is not. Okay, left is normal X-ray, right, worn away cartilage affected by a decreased joint space. Left, normal X-ray. Okay, it could be not selected and defected. Okay, joint space narrowing where there is more stress. Subchondral bone has weakened, bony overgrowth. This one is site loss of joint space. This picture impressing more information. Significant joint space narrowing. Okay, left and right. Normal hip, right is there is some joint space medially, but the superior portion is completely destroyed. Superolateral aspects affected most because the veins is transferred through the roof of the acetabulum, not the sclerosis and osteophyte formation. Okay. Painful bone on bone contact SEM, joint and the large bone. What to look for in an X-ray? Radiographic changes are visible relative late in the disease. Subchondral sclerosis, joint space narrowness where there is stress, subchondral cysts, osteophytes, bone mineralization should be normal. Clinical features and diagnosis: pain, sources, joint diffusion and stretching of joint capsule, torn menisci, inflammation of periarticular bursts, periarticular muscle spasm, and psychological factors. Debating related to the joint, slow in onset, worsened with activity in the internal stages, occurs at rest with advanced disease. Exam: joint line, tenderness, bone enlargement of joint, and plus and minus affection, thraptus, decreased range of motion. Joint exam: an evaluation of joint line pain, performs a varus or valgus stress test, applies stress across the joint, place fingers directly over the joint line to assess for pain. A clunk may indicate a meniscal tear, or crepitus may indicate cartilage. Have the patient lie supine with the leg muscles relaxed. Compress the suprapatellar pouch with your thumb, palm, and index finger. Milk downward and laterally so that an excess fluid collects on the medial side. Tap gently over the collected fluid and observe the affection on the lateral side. A fullness on the lateral side indicates the present of small knee effusion. Involved joints: deep and deep, first couple, mesh couple, cervical, lumbar, face joints, first metatarsophalangeal, hips, knees, and common, wrist, elbows, shoulders, ankles. OA disease management. OA is a condition which progresses slowly over a period of many years and cannot be cured. Treatment is directly decreasing the symptoms of the condition and slowing the progress of the condition. Functional treatment goals: limit pain, increase range of motion, increase muscle strength. Okay, treatment: non-pharmacokinetic, no proven medication-based disease-modifying intervention exists. Analgesics, acetaminophen, NSAIDs help pain symptoms, but controversial for long-term use in non-inflammatory OA because of risks versus benefits. Narcotics, intra-articular steroids, chondroprotective agents, antidepressants. Intra-articular hyaluronans. Evidence shows they have a small advantage in terms of pain control compared to intra-articular clubbers or anti-AIDs. No evidence for improvement in function. 2 studies comparing intra-articular steroids to hyalurons have come to opposite conclusions. More trials are needed. Intra-articular corticosteroids, beneficial in knee, lower 1A, beneficial in hip, lower 1B. Short duration benefits, 2-4 weeks, every 3 months, okay, not effective at 2 years. Or a non-operative treatments, pain medications, physical therapy, walking aids, shock absorptions, realignment through orthoscopy, limb strains affected areas. Surgery: arthroscopy, cartilage transplantation, joint replacement. Proximal tibial osteotomy. The result is that the weight-bearing line of the lower extremity moves more medially. The end result is that there is more pressure on the medial joint surface, which leads to more pain and faster degeneration. In some cases, relaxing the ankles and the lower extremity can result in shifting the weight bearing the line to lateral compartment of the knee. This pattern places the majority of the weight-bearing force into healthier compartment. Result is reduce the pain and delay the progression of the degeneration of the medial compartment. Osteotomy. Realignment of joints. Transfer weight to length involved part of joints. Sixes and sevens. Less popular, does not provide good long-term. Total joint replacement, considered the last solution of arthritis, improved ambulation, decreased pain, increased ROM, 90% plus good to excellent results. Arthroscopy with a lavage and debridement. No benefit for unselected OA, mechanical or inflammatory causes. 1B, mostly G.B. et al., a controlled trial of arthroscopic surgery for osteoarthritis of the knee. Kirkley A. et al., a randomized trial of arthroscopic surgery for osteoarthritis of the knee. Surgical arthroscopy. Arthroscopy is not recommended for non-specific cleaning of the knee. Is it to fix specific structural damage on imaging, repairing meniscal trees, removing fragments of the torn meniscus that are producing symptoms? Okay, thank you guys and take care.